most common human cancer. It affects about 6 lakh to 8 lakh patients per year in the US. We don't have current data of Pakistan right now. It usually affects male more because of their more sun exposure, which is not in case in Europe and America, but it's generally more common in Pakistan. It is very common in head and neck areas. Squamous cell carcinomas affect mainly of aged people of 60 years or more, and BCC affects relatively younger patients. The most common positive agent is sunlight, which is UV radiations. Skin colors also have a role in it. Fair colored individual patients are generally more affected. There are few chemicals like arsenic, which is very common positive agent, especially it causes Bowen's disease. There are a few syndromes associated with this skin tumors. Xeroderma pigmentosa is really common, and we usually see a few patients in our OPDs day in and day out. Albinism is also another syndrome associated with these kinds of skin tumors. As we all know, that skin is the largest organ, and it functions for thermoregulation, protection of internal organs. It gives you sensation, it prevents you from any harm, and it has a metabolic role in regular temperature. It mainly comprises of epidermis and dermis. Epidermis has several layers, which are corneum, lucidum, granulosum, spinosum, and basal. The upper layer, the corneum, is a dead layer, and it is of significant thickness in palm and sole, but it's of really thin. It is really thin in upper lid and lower lid areas. Similarly, basal layer is basal, which forms the skin and forms the epidermis. There are a few conditions like actinic keratosis. Actinic keratosis is basically skin damage due to the solar radiation or sun. It is the most common precursor of skin tumors. It progresses to malignancy in about 5 to 20% cases, and you can easily prevent it by application of 5-fluorouracil, or if there is a severe condition, we can easily excise it. This is the histology of actinic keratosis. It is of normal skin, but has changes. Now, the other condition is Keratoacanthoma. It is a nodular lesion with which has a center portion of keratin horn or keratin pearl. It usually spontaneously resolves over a period of few weeks or months, but it is now considered as a carcinoma in situ, which means it is now considered as a small cancer. But it resolves spontaneously in most of the cases, and if that's not the case, we can easily excise it. This is the histology of Keratoacanthoma, and you can appreciate the upper portion, which is in pink color, eosinophilic color. That is the keratin horn, keratin pearl. Bowen's disease is a precursor of these skin tumors like carcinoma in situ, which is written here. It is the reddish flag-like structure, which is irregular, which has a regular border, and it is most commonly because of arsenic exposure. This is the histology showing placids or encapsulated areas of eosinophilic cells. Now, basal cell carcinoma, it is generally a raised ulcerative or nodular lesion. It has a very good vascular supply, so it tends to bleed easily. There are many types of basal cell carcinoma, but all have one thing in common, that they have cells arranged in a placidin manner, which means that they are surrounded by a layer of these basophilic cells. Pigmented basal cell carcinoma is an example of, is a type of basal cell carcinoma which produces blackish to brownish pigment, and it is often mistaken from melanoma. We get to melanoma later. It behaves similarly to the nodular type of basal cell carcinoma. here is an example of superficial basal cell carcinoma, most commonly in our region. There is a scaly patch of skin. It has a irregular border, mainly affect the extremity. Morpheaform basal cell carcinoma is an example of very highly aggressive tumor. It is very difficult to treat because you cannot really appreciate the margins in this case. And we need to do Mohs surgery, or Mohs surgery is a type of surgery which get into liver, but in our department it's not available. Actually, it's not available in our country as well. This is the histology of morphiform basal cell carcinoma. Now, basal cells can be arranged. There's a distinctive thing in this histology that they have these, basophilic placids, which can show like these sound tissue. Now, the cystic basal cell is a cystic form of basal cell carcinoma. It can be differentiated by squamous cell carcinoma or a sebaceous gland. There is a cystic space generally present within the tumor and is filled with fluid or some sebaceous material. Now, there is a adenoid type of basal cell carcinoma. In this, the whole placid is lined with the epithelium type or the columnar type of it. You don't have to remember all of the types, the general things like which one is the most aggressive, which one is, what are the general types like nodular, superficial, spreading that. Basal cell carcinoma behaves in a locally invasive manner. I mean, it invades into the tissue. If you not treat it early, it can get into the bone, the skin, and everything. There is a negligible metastasis rate, but it is there. It is like 0.1% at max, but we happen to see a few of this case. Basal cell behave in a very predictive manner. I mean, it travels in the embryonic diffusion planes. If you can see your face, there are distinctive lines like nasolabial groove here, preauricular areas here. So if the tumor is here, it cannot cross these anatomical landmarks and it goes downward. There's another tumor, squamous cell carcinoma. Similarly, caused by the sun exposure, and it mainly affects the elder people. Actinic lesion, as I already told you, the sun exposed area, sun damage the skin. There's a 3 to 5% chance of the formation of squamous cell carcinoma. And other scars, chronic inflammation can have a 10 to 30% chance of developing a squamous cell carcinoma. This carcinoma invades deeply. It is a very aggressive tumor and it has a perineural invasion, which means that it grows along the perineural space or around the nerves of the skin. Adenoid squamous cell carcinoma is an example. In this carcinoma, you can see few pathological characteristics like this keratosis, which means that there is a keratin deposit within the cell, and acantholysis, which means that the cells dislodge from each other. There is another example of recurrence squamous cell carcinoma in which you can appreciate that there is an eosinophilic material dispersed throughout the slide, and there is small cavities which were initially filled with some material that dispersed out during the slide formation. But these are the characteristics of squamous cell carcinoma, that you get these hollow spaces and the keratin pearl. The spindle squamous cell carcinoma is the least common type. It is poorly differentiated and it doesn't have those keratin pearls, but this is a squamous cell carcinoma. So the staging of squamous cell carcinoma and basal cell carcinoma is this, that you don't have to remember each and everything, but it's quite simple actually. The T1 or the tumor stage 1 is when the size of the tumor is less than 2 centimeters. It is T2 when the size is less than 2 centimeters or it's up to 5 centimeters. And the tumor size is more than 5 centimeters, T3. And it's T4 when it invades deeply into the structures other than skin, like cartilage, muscle, bone. So, for nodal metastasis, if it is present, it's N1, if it's not present, it's N0. And similarly, the metastasis, if it is present, it is M1, if it's not present, it's N0. So basically, you have to just remember the primary tumor or T-staging of this tumor. There are plenty of treatment for squamous and basal cell carcinoma. There are some destructive treatment like lasers, curettage, dermabrasion, which are useful for small BCCs but not for SCCs. If the BCC is of T1, which is less than 2 centimeters, it can be cured up to 80 to 90% cure rate with these type of treatments. These treatments are quick, easy, but there is a disadvantage that you will end up having an open wound or a scarring post-operatively. Similarly, lasers are the type of destructive treatment. Patients with medical diseases which are not fit for the surgery, like uncontrolled blood pressure or any uncontrolled comorbidities, can be treated with these lasers. And if there are multiple lesions and the patient doesn't want to get operated on the multiple sites, you can get it through lasers. Cryotherapy is also a type of destructive treatment. You can use it on a very small, very well circumcised lesion that has a temperature of minus 30 to minus 50 Fahrenheit. It has an advantage of quick in-office use. Your dermatologist can easily get cryotherapy, curettage after the cryotherapy, and it will end up in a small scar. The only disadvantage which we face in destructive treatment is that we cannot get a material for histopathology. I mean, if you disrupt the lesion, you can never be sure that it was a BCC, a SCC, a melanoma, or something else. So the treatment we generally offer is excision. It's most commonly used by head and neck surgeon and as plastic surgeon. There's a cure rate of 95%. There's the advantage of specimen collection after the surgery, and you can evaluate it under the microscope, and you can be sure that it is completely excised. For the complete treatment, we need to excise it to the margin of 3 to 5 millimeters. For BCC, it is recommended that the millimeter should be 4 millimeters. Sorry, the margin should be 4 millimeters. And for SCC, it is recommended the margin should be 6 millimeters. So there's a general consensus that if you excise a lesion with a 5 millimeter margin, you are generally safe. Now, the Mohs surgery is not a common thing in Pakistan or in any other underdeveloped country. It is generally offered in very few centers in the US only. It has a cure rate of 96 to 99%. There is a very specific indication of this Mohs surgery. The lesion is very small lesion, T1, less than 2 centimeters, and it is in a high risk area of the face. You can treat it with Mohs surgery. What you do is you don't actually remove the lesion with a margin of 3 to 5 millimeters, as we have already discussed. You just remove the lesion just next to the lesion, and then you check it under the microscope and see if there is any visible tumor, and you take it out. It is a time-consuming, really expensive procedure, and it's not usually suitable for all.
डॉक्टर उबैद जी सर थोड़ी सी आवाज आपकी अनक्लियर हो रही है, अगर पॉसिबल है तो आप या तो
मैं देख लेता हूं, जोर से बोल
जी. थैंक यू.
Now, other treatments like radiation is also possible. That prolonged course of radiation can give very good results with this squamous cell carcinoma and basal cell carcinoma. But as you all know, that radiation are carcinogenic. It has an effect on the skin, the underlying bone. The underlying bone can get osteonecrosis with the radiation, and you cannot usually limit yourself to a certain margin during the radiotherapy. Chemotherapy is not usually recommended for squamous cell and basal cell carcinomas, but you can actually weaken the tumor by applying cisplatin or by applying 5-fluorouracil. Then by radiation, you can actually destroy the lesion. There is a role of regional lymphatic treatment for this kind of squamous cell and basal cell carcinoma. If the tumor is invading deeply, it is T4 in nature, you have to check the regional lymph node and you have to address them. If the tumor is more than 2 centimeters, you have to check and address the regional lymph node. Residual tumor had generally travel to the regional lymph node and need to be treated. Every tumor goes to a specific set of lymph nodes. For example, the lower lip lesions generally go to the submental or submaxillary lymph node. Similarly, a lesion on the nose or on the nasolabial groove generally goes to the submaxillary lymph node. So you have to know these things, not to a certain extent that you just have to clear your exam, but these are not very important things for you. So this is the general treatment for any basal cell carcinoma and squamous cell carcinoma. If it's a primary tumor, you can go for excision or you can go for Mohs surgery, which is not available in our setup. If the location is high risk, which is central face, ear, nose, chin, areas of cosmetic importance, you can go for Mohs surgery. Otherwise, you can go for excision. In our setup, we used to go for the frozen section. Frozen section is when you take out a tumor, you send the margins for histopathology at the same time, and the histopathologist told you that it is completely excised now. If not, you can take out more. Recurrence rate is 1 to 39% in BCC, and it is up to 75% in squamous cell carcinoma. Nodular type has a recurrence rate of 1 to 6%, but the Morpheaform, which I have already told you, the most aggressive form, has a recurrence rate of about 30%. Recurrence rate is higher if the size of the tumor is more than 2 centimeters, or if it is invading the underlying structure like bone, cartilage, and anything. And if there is a lymphatic involvement, there is a more chance of recurrence. There are very few people in Pakistan which die of the basal cell carcinoma, but there are many cases of squamous cell carcinoma mortality worldwide and in Pakistan. Now, there's another type of tumor which is malignant melanoma. You can generally divide skin malignancy into two types: squamous cell carcinoma, basal cell carcinoma, and malignant. So the malignanoma is a tumor arises from the melanocyte of the basal layer of epidermis, and it can rarely arise in eye and in the subungual area, which is under the nail area. Its incidence is quite shocking that in 1996 it was reported that 181 cases, new cases of melanoma were reported in US in 1996, but in 2019 more than 23,000 cases of new cases of melanoma are reported in the US and 132,000 cases worldwide. It is a highly aggressive tumor, and it's an average 28 deaths due to the melanoma each year out of 100. Risk factors are quite different from the squamous cell and basal cell carcinoma. It usually arises from nevi, which is mole, जो आमतौर पर तिल कहलाता है, freckles, sunburn areas, and the family history of melanoma are the risk factors for melanoma. Patient education is really important in all of this squamous cell carcinoma, basal cell carcinoma, especially in melanoma, that if you have a family history of melanoma, you have to be careful. You have to check all the lesions, smaller ones and big ones, on your body for this melanoma. And if the lesion has few characteristics, which I get to you. Family history is really important, but most of the melanomas are sporadic, follow the sporadic pattern. 2 to 10% patients have a positive family history, and if the parents have a patch of black skin, which is generally commonly known as birthmark, or uh, the medical term is CMN, congenital melanoma nevus, you have a small tendency to develop this melanoma. निवाय जिसको हम तिल कहते हैं, इसमें बहुत सारी टाइप होती है कि बहुत बड़ा है, you can call it a congenital melanocytic nevus, which is a very common thing. It has incidence of 1% newborn, and it has a very high risk of melanoma formation. There's an illusion that sunscreen prevent these kinds of skin cancer, but it is not true. It gives you a false security against the sunlight, and you can spend more time in sun after applying these products, but they are not generally protective against this kind of lesions. There are few things which we need to know about melanoma, that if the lesion is asymmetric, which means that the small portion of this lesion is a darker color, or a small portion of this lesion is a lighter color, or if it is changing the size of it, or it is changing the color, if it is causing itching, it is oozing blood, it is the melanoma. So it is easier to remember by the American system, which is A, B, C, D, E. If it is asymmetric, if its borders are irregular, if it is changing color, its diameter is more than 6 millimeter, or is there any other finding on examination like enlarged renal lymph node, you can consider that lesion as a melanoma, and you should get the biopsy. There are a few types of melanoma, like there's a nodular type, which is common in males. It is generally common on the trunk area. It is black to brown in color and tends to bleed and ulcerate commonly. There is the superficial spreading type, which is more common in female and in the fair-colored individual, which commonly occur on the lower limbs of patients, but it is a very aggressive tumor because the area in between these two lesions, which I am showing you, is also a melanoma, which is a melanoma type. And you can appreciate the asymmetry, which is that there's a reddish portion in between as well. That is the asymmetric region. And the borders are irregular. The color is changed from one place to the other. So it is a melanoma. Acral lentiginous melanoma is a type which is generally occur in a fair-colored individual. It is a commonest type in non-white skin nation like us. If you have a lesion in your foot which is of darker color, it is growing and is changing its color, it is a melanoma, but you should check it out. Now, there's a type of subungual melanoma. It is a rare type of melanoma, but it is generally present in our population. And as we don't bother checking our toes or feet for this kind of lesion because of lack of awareness, we can miss these things. One of our medical students from the Academic state had this condition. It came to us, and we need to remove a large portion of her thumb. There is a sign which is called Hutchison sign. You must have read this. It is a sign in which there is a linear, darker ridge on the nail. That is something different, but it can be a melanoma if it is involving the pulp. I show you. There is a type of melanoma which is called LENTIGO malignant melanoma. It is occurred generally in the late individual. If you have encountered a male patient or a female patient of late 80s and 90s, you can easily appreciate that the skin of that individual has some blackish marking. Those can be LENTIGO melanoma. So the melanoma can also be amelanotic, which means that it can be of red or normal skin color, which is generally misdiagnosed or not diagnosed diagnosed as melanoma and cause death in our patients. Melanoma it has a high chance of metastasis, and generally patients came with this kind of condition, which they have multiple metastases and a single lesion which is not being treated for many years. So the prognosis is very scary in the case of melanoma. I mean, if you can just see the 5-year survival. 5-year survival is with the diagnosis of the lesion, how many out of 100 patients survive 5 years. So if the lesion depth is 4 millimeter or more than 4 millimeter, you can expect that 50% of the patients will not survive the 5-year mark, or will not survive for more than 5 years after the diagnosis, despite all the treatment they take. So what is the The scalp lesion have a poor prognosis because they tend to spread on different levels of lymph nodes. There is a chance of spread quickly. While in palm and sole, they can be easily caught up, but if there is a lesion under or the sole area, it can be missed for many years. Younger patient appears to do better with this kind of melanoma, and women tends to have a better prognosis than. If there is an ulceration present on the tumor, it is a higher risk factor, and there is a high chance of metastasis already. Surgical excision with 1 to 3 centimeters is recommended in melanoma, while in BCC and squamous cell carcinoma it is recommended in millimeters. It's a very different thing. Invasive primary melanoma on the digit can be treated by amputation, but we can also offer the partial amputation to preserve the function of the. You need to investigate all melanomas of more than 1 millimeter for metastasis, and this is really shocking. I mean, if there is a mole on your body more than 1 millimeter, and if it is a melanoma, there's a chance of metastasis. These are some PET scan of the patient of 1 millimeter, 0.75 millimeter lesion, which end up in plenty of metastasis. So follow-up period is very important after the treatment. There is no general agreement of time period in which you need to follow. It is generally recommended that you need to follow a patient for approximately 10 years post-operatively, and you need to examine the scar, the local lymph nodes, the spleen, the liver of the patient every time. Plantar malignant melanomas are really common in our society. It is like 29 to 46% patients of Asian origin, and it is far more common in dark individuals like African. Subungual melanoma can be differentiated from the subungual hematoma or the Hutchinson sign. You can see the Hutchinson sign on the lower left corner, which is the streak of blackish pigment in the fingernail. In the left upper corner, there is a sign which is called subungual hematoma. This is not a tumor; it is a hematoma which forms under the nail. But you can differentiate it with the neighboring images that the pulp of the finger is involved. If the pulp of the finger is involved, or around the nail, there is any black spot, then it could be a melanoma. So the conclusion, it is a common tumor. You need to take good care from the sunlight and don't rely on the sunscreen infections. You can prevent new lesions by sun protection, which is the reduced exposure time to the sun, but you cannot prevent it by just applying the sunblock. Thank you. You may now raise your hand if you have any questions.